Okay, we're going to get started. And Thursday is Thanksgiving Day, so I wish you all a happy holiday. And today our first speaker is Jun Wei. He got his PhD degree at Baylor College of Medicine. Then he did postdoctoral training at the National Genome Research Institute with Paul Meltzer. And Paul came to the genetics branch, and June joined Javed Khan's lab, and now he's in the genetics branch. And they're in the oncogenomics section of the CCR. The title today, The Application of Genomics to Identify Diagnostic Biomarkers, Drivers, and Therapeutic Targets for Pediatric Cancers. June.
Thank you, Terry, for a nice introduction. And thank you for coming in this cold weather to attending to this lecture. And really my honor, it's really my honor to tell you how we use genomics to study the pediatric cancers in our section. Okay, this is the outline for today's lecture. First, I will introduce you the success and the challenges of treating pediatric cancers. And the second part, I will tell you what is the genomics. And the third is this technologies using next generation sequencing to study genomics. And I will give you two examples. How do you use next generation sequencing technology for the practical use to study pediatric cancers in terms of diagnosis and also the identification of molecular target. And lastly, I want to touch a little bit on the precision therapy, which is the new wave of the clinical care for the pediatric cancer. So this slide showed that in the childhood cancer therapy, with the modern therapy, the survival rate is really increased in all kinds of pediatric cancer. Here show the leukemia, lymphoma, and the Wells tumor. And the blue show this 60s survival rate. With 90, you can see most cancer survival rate is in the 80% or even 90%. So this is such a successful story for the pediatric oncology research. It's a successful story. And this is the same graph that shows the mortality rate is keep declining from the 70s to the 90s. However, in the recent several decades, you see this decreasing of mortality rate is plateaued, okay? And that means probably this kind of approach using empirical approach to fine-tune the therapy is reached to its maximum effectiveness. And in some cancers, for example, in some leukemia, the survival rate, as I've shown, it's pretty high, but the high-risk neuroblastoma, you can see the survival rate, even in 90s, it's still pretty low. And some tumors, for example, the tumors in the brain stem is very low. And in some other sarcoma, for example, Ewing sarcoma, the localized disease, you can see the survival rate is very high. But in the distant metastasis disease, the survival rate is very dismal. And the same trend we'll see in the rhabdomyosarcoma. If you have a metastatic disease, the survival rate is very low. So despite the successful improvement of successful rate for the childhood cancer, and a certain tumor, especially those metastatic tumor, the survival rate for those patients is still very, very low. And this slide just shows you that how important the genomic is And we know that let's stand back a little bit to talk about the phenotype and genotype. And in this slide, show you this dramatic change of morphology from this caterpillar to this butterfly. You have to think, this is the organism share exactly the same genome. However, they look so different, right? So that's the genomics. So this is all the result of dramatic consequence of gene expression of the genome. So it's the same genome, but I have a different expression pattern, and the result into different proteome, and in different tissue, and the result in the different physiology. Okay, very different. The same genome can result in such a difference. This is the same in human too. Okay, we all come from the single fertilized egg, but in our body, there's so many different kind of tissues. There's skin, there's gland, there's epithelial, so on and so forth. I don't need to bore you with all this, but the same kind of idea is the same genome, and you have a different expression pattern and different protein, and different resulting in different tissue, different physiology. So this is in early 90s, the study of the human genome. So this human genome project really is a landmark to decode the human genome, so that now we have a map to really know what a human genome look like. And it's really, this project is greatly facilitate the advance of the genomic research. This slide summarizes, the central dogma of biology, right? So the genetic information flow from the DNA, this is chromosome, DNA, and to translate it, transcribed into the mRNA, messenger RNA, and then got translated into the protein. So that's the central dogma of the biology. The information flow this direction. And of course, there's a regulatory feedback. The protein, we know that it can regulate the DNA and the mRNA level. And recently, we also know there's some regulatory RNA, for example, microRNA. They can also regulate the transcription from the DNA to the messenger RNA. Also, they interfere with the translation. They regulate the translation. Also, themselves, they can self-regulate. So it's a very complicated system, but this is the current understanding of how this genetic information flow. And this is in terms of the number of those molecules. The DNA, we know we have 3 billion base pair of DNA in every cell of our human body. And so these 3 billion base pair DNA encode about 25 to 30,000 genes. And with the alternative splicing isoforms, there's about 150,000 different species of messenger RNA. And there's also about 1,000 microRNA and over 10,000 non-coding RNA. Those are all the regulatory elements to regulatory the process we just talked about. And the protein, this is our estimation. We think it's about 500,000 different kind of protein result from this alternative splicing or the variant. So this genetic information flow resulting in this protein, and this protein is really the building molecule for manifested phenotypes, right? So in cancer, it can to really this is a protein that causes the specific characteristic of the cancer, and also we can use this protein, the phenotype, to diagnose the cancer, and also to affect the response of the treatment, cancer treatment. And the recent ENCODE study also revealed that most of genome, about 80% of the human genome actually is functional. Before the ENCODE study, we don't know. We know these 3 billion base pair of DNA, it's only 1% or 2% is coding DNA. The rest, we call it, so-called junk DNA, people call it. But now the ENCODE shows that about 80% of the genome actually they're being transcribed and they have function. The major function is the regulatory function to ensure the right time, the right place, and the right moment that the protein is, the gene is transcribed and the right isoform of protein is expressed. So in the genomic research in the cancers, the key is to use genomics to identify the biomarker, the driver, and the target. Okay. And the perfect scenario to identify this is if we can identify a biomarker, which is the molecule that we can measure objectively. Okay, for example, just like our blood measurement, right? The red blood cells number, those kind of, it's all biomarker. You can objectively measure it. So if you can identify a biomarker, and hopefully the biomarker is specific to cancer, so that's the reason we call it the driver, which is specific to the cancer progression or to formation of the cancer. So this biomarker can not only as a marker to indicate that there's a cancer, also they can drive it at the biology level. This biomarker also drive the formation or progression of the cancer. If we can identify such a driver, then we can devise therapeutic method to interfere with this driver. So this will be this therapeutic target. However, in some case, the biomarker can be the therapeutic target directly, but not necessarily the driver. For example, if there's a cell surface molecule that is specific to the cancer cell, but not necessarily to drive this cell, but it's specific enough, we can use some antibody therapy or other things to target this molecule in order to target the cancer. So that's the reason sometimes the biomarker not necessarily be the driver, but it can be also the therapeutic targets. In any case, all this kind of scenario we requires that this kind of biomarker or driver or therapeutic target, they have to be low enough or no expression in the normal tissues, but only expressed in cancer, right? That makes sense, right? So that's the genomic research will try to target those kind of molecules specific to cancer, but not either low expression or no expression in the normal tissues. So that's the goals of the genomic research in the cancer field. So here I want to introduce you to this technology, which is called the next generation sequencing, also called a massively parallel sequencing. You will see why it's called a massive parallel sequencing. The idea is, in the old time, there's one kind of genetic tools. It's called a shotgun sequencing. So if you have a human genome, it's a lot. It's a 3 billion base pair. It's very hard to sequence in the old time. So what they do is they fragment into different fragmentation, and then they clone into the vectors, and they just sequence piece by piece, right? That's the traditionally sequencing of the human genome. With this kind of method, the first human genome project spent about 13 years, 13 billion base pairs, and about 10 years to finish one human genome using that kind of method. But during that period of time, the crack inventor, they used another approach. It's called shotgun sequencing. Shotgun sequencing is just use the human genome DNA. they randomly fragment it, and then they just randomly pick those a clone into the certain sequencing primers, and they just use the sequencers to randomly pick clones to sequence them. So that way, you can eventually you can create a contig because they are overlap. You can build up this long fragment. Eventually, you come back to the human genome. So this idea, next generation sequencing, is similar to the shotgun sequencing idea, which you have genomic DNA here, and you just fragment all the DNA, and you do a size selection. That's just for easy to PCR. And then you put a sequencing adapter on the two ends of the fragments, and then you amplify this library, and you sequence on the next generation sequencer. And eventually, all the sequencing you get back from the sequencer, you line up with the reference genome. Because we are already, at this point, we have the human genome sequenced. We know what the genome sequence look like. So you can line up with the reference genome. And then from all this experimental sequencing, you can see what exactly sequencing in the original sample here. So that's the idea. And this is a real picture from a next generation sequencing sequencer. So each little square here you can blow up is this picture. Each little dot is one sequencing. Okay, it's equivalent to one Sanger sequencing. Okay, so each spot is one Sanger sequencing, and there's hundreds of million spots in the flow cell. Okay, this is only one little spot view of the whole flow cell. So the whole flow cell has like hundreds of thousands of these fields. So you let the DNA flow through this flow cell, and then you sequence it. You take those pictures, and then you sequence by synthesize. What kind of genomic information you can get from this sequencer? This one showed that at the DNA level, you can really detect the point mutation. For example, this is a reference genome. And if you have a reference genome at this position is a letter A, however, in your reads, your letter is C, then you know that your sample has a mutation, point mutation, A to C point mutation. And in this case, it's an indel, because you line up your reads to the human reference genome, and this little sequence is missing in all the reads in your sample. Then there's an indel. And also, if there's no reads in one region, the reads is absent, then it's a homozygous deletion. There's nothing there. And if you do compare with the normal samples, you will see the coverage of a particular segment is reduced. Then you can know it's a hemizygous deletion, okay, because the counts of the coverage. And then, of course, you can detect the gain or amplification. Or if you detect the junction that is not natural in the original human genome, but two sequences coming from different chromosomes, then you know there's a translocation. There's a breakpoint and cause the translocation. Okay. So another thing is you can also see those reads coming from the experiment cannot map back to the human genome, but you can map to some non-human sequences, for example, the virus or bacteria. Then you know in your sample there's a pathogen presence. So this is at the DNA level. And this slide shows you at the RNA level, you can do the similar thing. First, with the RNA transcriptome sequencing, what you can do is you just like a microarray, you can by the counts of the reads from a gene, you can kind of know how much a gene is expressed, right? So this is called a digital gene expression. The reason it's digital because it's by count. It's not by the analog signals as seen in the microarray experiments. And since we have a base pair resolution by sequencing, that we will know that express the mutation. If the mutation is there, it will be expressed or not expressed, we can immediately tell. And since the RNA has to go through the splicing to become a mature mRNA, and then using this sequencing technology, we can detect alternative splicing event. Because the junction, we can see the junction right at the exon-exon boundary. So we know exactly which transcript coming from which kind of splicing pattern. And another very important feature of the RNA sequencing is to detect the expressed fusion transcript. Remember this fusion gene? If it's landing to a coding region, they can fuse together and get a transcribed fusion gene. And then we can detect it readily. Okay, this is a very important feature. And also there's other things like RNA editing and novel transcripts and the non-coding RNAs. And this technology can really study all these kind of events. What's the good of the next generation sequencing technology? This slide shows that compared to the old high throughput method, for example, like the array-based technology, this next generation sequencing technology has no need to prepare clones for DNA fragments, right? So it's one shot, you can have all the DNA species detected in the sample. And then there's no need of prior knowledge for the probe design, which is absolutely required for the microarray. Microarray, you can only detect the things that you kind of know. If it's a new transcript or if it's a mutate, like a deleted gene, it's really hard to detect because you have to design a specific probe to detect the specific events. And another thing is it can able to detect the balanced genomic structure change. For example, if there's a balanced translocation, this kind of event is almost impossible to detect in the array-based format because there's no net gain or loss of genetic material. The array cannot detect that. But next generation sequencing, you can detect that. And of course, the parallel sequencing is giving the base pair resolution and at a very massive throughput, and it can give you extra information in terms of mutation. And you know, here I call it the cheaper and faster per genome. Okay, per experimental-wise, now it's still pretty expensive. For example, nowadays, if we want to sequence a whole human genome with the next generation sequencing technology, it still costs about tens of thousands dollars to sequence that. But compared to the first genome, we spend like billions of dollars to sequence one genome, right? So it's much cheaper and faster. You know, the first human genome takes something like 10 years. But nowadays, you can sequence one human genome at 40x or 50x at almost overnight. You can do that. Okay, so this technology is a very powerful technology. This slide just shows that we can get all different kind of information. For example, I showed you from the DNA, we can do the whole genome or genome partition. This is all variation of the genomic sequencing. Genome partition is you can use a probe to only capture the part of genome you want to sequence. For example, the coding region. Okay, you can design probe to only target the coding region. So you do not spend a lot of sequencing ability to sequence those intergenic regions. And also you can study methylation and the ChIP-seq and the transcription factor or enhancer, the binding area. So you can get all different kind of information from sequenced DNA using different variation, various technique. At the RNA level, you can, as I show you, you can really sequence the messenger RNA and also non-coding RNA, including microRNA, other non-coding RNA. But interestingly, all these things you can get from the same platform, okay? So one platform, one generation, next generation sequencer, you can generate all these kind of different information for your sample. I already gone through this, so I'm not going to go one by one. So again, the goal of this is that we can discover the biomarkers for diagnostic or prognostic information, and we can understand the biology to identify what is the driver to driving the tumor initiation or progression, or identify the therapeutic target. I will give some example later. And this slide shows one example of the application using gene expression profile to diagnose cancer. And actually, this data is coming from the microarray, the early microarray experiment. This is using the Affymetrix microarray. And we did a whole genome expression profiling of the tumor. And this gray dot represent a tumor that this tumor, the clinician has a question about this tumor. They do not know if it originally was diagnosed as a Wilms tumor, which is a kidney tumor. But in the clinical process, they are not sure because it's doesn't look like a typical Wilms tumor. So they come to us to ask what kind of tumor it is. So we did this gene expression profile. From this PCA, you can see this is instead of a cluster with this Wilms tumor showing yellow here, actually the cluster with neuroblastoma tumor. So eventually we changed the diagnosis from Wilms tumor to neuroblastoma. And the patient was then switched to high neuroblastoma treatment, including the stem cell transplant. And this patient actually doing well after 1 year of the diagnosis. So this is really a good example to say use the molecular diagnosis, use the genomic tools to diagnose the tumor. Sometimes it's much more accurate than the like a regular histopathology diagnosis. And this is another example shows that use next generation sequencing of transcriptome data, we can really distinguish the two subtype of rhabdomyosarcoma. So this red represent here is a fusion positive tumors, which those tumors are possessing a typical fusion molecule that drive those tumors. And this category tumors, it's all fusion negative. They do not driven by the fusion events. Instead of they are driven by the mutations in RAS pathway and also other kinase pathway. So you can see using the next generation sequencing the RNA sample, you can readily distinguish these two subtypes. And another example to do the diagnosis is to detect the fusion gene. fusion gene actually it's a very important diagnosis marker for the pediatric cancer. There's many pediatric cancer. For example, rhabdomyosarcoma, I just show you the fusion positive. They have this PAC3 FOXO1 fusion, typical fusion. Or this is Ewing sarcoma, have this EWS FLY1 fusion shown here, 11 and 22 translocation. Oh, sorry, I need to let you know what this kind of graph represent. I don't know how many people familiar with this graph. Okay, good. Let me just, for those people who do not know the graph, just explain to you briefly. So this graph actually is the whole, it's called the circus plot, and it has multiple tracks from outside to inside. Okay, this out track is to represent the human genome. This is chromosome 1, 2, 3, 4, so on and so forth, all the way to 22, and then this is sex chromosome XY. And here, the second track here is represented the copy number, okay? You can see this probably represented 2 copies. And if higher, that means there's a duplication of the chromosome. For example, here probably you have a higher copy number, maybe a gain of the whole chromosome of the chromosome 5 in this tumor. And from here you can see this probably is a boy because it only have 1 X chromosome, right? And in this case, the rhabdomyosarcoma case, you can see that this chromosome has a deletion, okay? So 1 copy deletion. So you have chromosome 11 at the beginning, 11p has a deletion. You can see the copy number is lower. And the inner track here, it shows the heterozygosity, okay? If there's a dot here, that means there's loss of heterozygosity. And this inner track is the variance track to show that there's a variation of the sequence from the reference genome, which is the human genome, okay? So the utility of this using whole genome sequencing, immediately you can see what kind of tumor it is because those are characteristic of translocation. Okay, it's very easy to detect with this technology. And also at the same time, we can detect the novel in-frame fusions. For example, this is 1 sample of a rhabdomyosarcoma, and we detect a fusion in the DNA. It's a PAC3 instead of a fusion with FOXO1, the typical partner of the PAC3. This case, it's fused with the NOA80D gene, which is epigenetic genes. And you can see this region has a massive rearrangement in this sample. And this is RNA sequencing. Immediately, you can see this is a fusion junction reads to show this is fusion. And you know this gene fusion is not only fused at the DNA level, but also expressed in the RNA. So probably this is a functional fusion. And there's 2 cases when we do this sequencing of rhabdomyosarcoma. At that time, we get the sample from the COG bank, which is the tissue network bank. And there's 2 cases that are very interesting. We use whole genome sequencing. We detect originally histology is sarcoma. They said it's undifferentiated rhabdomyosarcoma. But we detect this ALK NPM1 fusion with the whole genome sequencing. And review the histology. Then we tell the tumor bank, they review the histology. And they said this is like a hematological malignancy. Probably it's a lymphoma, 1 type of lymphoma, which is also reported has this kind of ALK NPM1 fusion in the literature. So clearly, this is probably either the sample mess up or this misdiagnosis at the very beginning for this case. There's a second case is similar. We detect a rat NCO4 fusion by the whole genome sequencing. And this fusion has been reported in the thyroid carcinoma. So probably this is a similar thing. Either the diagnosis was wrong or the sample has been mislabeled. So from these two cases, we can say using this kind of technology, it's very easy for us to pinpoint what exactly the diagnosis of a tumor. And this is a study I want to show you how to identify the novel targets for pediatric cancer. And this study was conducted for a case study for a patient that has neuroblastoma. So this slide just shows you what is neuroblastoma. The neuroblastoma is a very aggressive childhood cancer, usually happen very early at the first 5 years of the life. So 90% of patients neuroblastoma happen at the before age of 5. They have very diverse outcomes. I will show you more data for that. And the survival for the patient with high risk neuroblastoma is less than 50%, despite of intensive multimodal therapies, including chemotherapy, radiation therapy, bone marrow transplant, very aggressive therapy. So this therapy can result very toxic, cytotoxic therapy can result in a high morbidity for those patients. And there's a high mortality rate and morbidity rate for this group of patients, especially with the patient, or especially those patients with a metastatic tumor. So novel targeted therapies are highly desirable. This is what stage 4 neuroblastoma look like. This is a bone scan. You can see the tumor is spread everywhere in the bone. And this is a big tumor in the adrenal gland. Okay, this is a tumor was taken out of adrenal gland. You can see this is a viable tumor cells and with extensive necrosis. You can see the histology is packed with tumor cells. Usually those kind of patients, their survival rate is less than 50%. However, this specific stage 4 disease for neuroblastoma, they call it stage 4S. Also, the patient you can see has a very extensive metastasis. Okay, this scan shows a lot of tumors, nodules in the patients. Same thing, packed tumor cells. However, this kind of patient, usually the survival rate is 90%. Okay, because those usually happen in the patient younger than 1.5 years old. And as long as you can keep the patient alive and the tumor, amazingly, they spontaneously regress. They just goes away, okay? So that's the interesting about this neuroblastoma. It's the clinical outcome is very diverse. And this one also shows the high risk of neuroblastoma. It's still a challenge for the treatment. The current best immunotherapy treatment, the survival is about 50%. So our section, the mission of our oncogenomics section is apply these genomic tools to really study the biology, to identify the novel target and the biomarkers, and then hopefully we can translate such findings to the clinic. And this is the neuroblastoma genome, and this is a large study by the target group, which is like the pediatric genomic study for the neuroblastoma. And this is a landscape global view of this type of tumors. You can see there's a lot of aneuploidy of the tumors, including the hyperploidy and the mecan amplification and the 1Q gain, 2P gain, and the 17Q gain, and the 1P loss, 3P loss, and the 11Q loss. Very extensively genomic rearrangement for those tumor. However, if you look at the mutation landscape, only a small portion of samples having known genomic mutation, including ALK, ATRX, PDP-N11, MECAN, so on and so forth. And also this germline mutation has been reported in CHEK2, PINK1, BARD1, POP-B2, TP53, and also DNA repair genes mutation. But look at this, the majority of the samples, actually, we cannot detect any mutations. Okay. And as a matter of fact, this tumor has the lowest somatic, is one of the tumor has the lowest somatic mutation burden, okay? And this is Bert Vogelstein's review paper published a couple of years ago. And you can see this is the most adult cancer is in this space, and this is the pediatric cancer. You can see it's all on the very low end of the mutation rate, and this is neuroblastoma. Okay, so this case study we did it. We performed the next generation sequencing several years ago. So when we first did, the first sample we got is from this diagnosis samples, which is from bone marrow biopsy at the diagnosis. The tumor content for this is about 80%. And then this patient went through the chemotherapy to shrink the tumor. Eventually, she went through the surgery to take out the primary tumor, as I shown before. And this is a marginal, this is viable tumor cells, and we took for the second samples as our primary tumor. And this patient, after the surgery, went through 3 years, all different kind of therapy. But unfortunately, she eventually succumbed to the disease. And at the autopsy, we took one metastasis tumor from the liver, her liver, as our third samples. The idea is to use those samples to really use the whole genome and the transcriptome sequencing to identify if we can detect any mutations that we can use as a target to treat the patient. The experiment design is as following. We first sequenced the index metastasis, which is MED2, with the germline DNA. We used the whole genome sequencing. We identified the somatic small variants, and then we look at we use the orthogonal resequencing to validate. In other words, we make sure that what we're looking, those mutation, are real mutation, not the sequencing artifact. And from then on, we went back, because this is index sample, we went back to original the sample at the diagnosis to see how many dose mutations at the very beginning sample. And also with these primary tumors, we have a different section. Because that tumor is pretty big, we want to see if these mutations is in all kinds of different parts of this primary tumor. And we also integrated the transcriptome sequencing to see are those mutations expressed in the transcriptome. Okay, this is the circus plot that shows that this patient has this tumor has a very extensive genetic genomic rearrangement. You can see this is lost heterozygosity of 1p and 3 and 11, 14, and so on and so forth. There's a gain of the copy number, and there's a bunch of translocation happening in this genome. And at some places, for example, these two example at the chromosome 4 or 13, you see at a very small genomic region, this is only like a couple of megabase, but you have this very extensive rearrangement that indicate there's a phenomenon called genome shattering. It's a chromosthropesis. So seems there's a catastrophic event happened to this genome, and the genome put back into this kind of really rearranged fashion. And there's one gene we're interested because in the literature has reported for this kind of high risk of patient, especially older patient. This patient actually is a very unusual patient. When she was diagnosed of neuroblastoma, she's 19 years old already, which is a very atypical neuroblastoma patient. And for those patients, older patients, in the literature reported the ATRX gene is usually mutated at a very high frequency. So we look at this gene just by looking at the reads coverage around this region, around this gene, and immediately you see there's a deletion for this exon from 10 to 12. There's a deletion, seems there's two joined. So then we designed a genomic PCR primer to verify this deletion, because if it's no deletion, the distance is too far. It won't have the PCR won't work. But if there's deletion, there's an abnormal junction, then you can result a PCR product. That's exactly what we saw in the diagnosis tumor, in the primary tumor, and in the very autopsy tumor. We can all detect this junction. But in the normal liver or normal skin, we cannot detect that. And we also sequence verified our finding from the whole genome sequencing. And this table just show you, you're not supposed to read those. The reason I put here is to show you this red, each row here represents one mutation. Okay, this red portion represents a mutation that is shared in all the samples. Well, this black is only detected in the this MED2 samples, but not in the other two samples. That means that there's accumulation, rapid accumulation of de novo mutation, somatic mutation in this patient. At this point, we don't know what resulted. It's just the heterogeneity of the tumor, or it's due to the intensive therapy. So at this time, we really don't know what happened. But this is very alarming, how much mutation, de novo mutation can happen. And also, there's mutations. We look at the expression. This panel A, this on the left-hand side depict all the shared mutation. This upper panel showed the expression of the genes that is shared, and the lower panel showed the mutant allele frequency in the sequencing data. So we can see that this gene, it's called LPR1, is the highest expressed mutated gene, and the mutation rate is pretty high, more than 50% in the sample, indicate this is an important mutation. And interestingly, if you look at the mutation that is unique in the MED2, which is the black columns I showed you in the previous slides, you see their expression is only detected in the MED2, not in the previous not in the other two samples. That's shown, that's consistent with the DNA data. So what is this LPL1? Actually, this is a G protein coupled receptor. And it's important for the neuron development, and also it's important for the cell migration and the differentiation, and also cell survival. And you can see this LPL1 is on the top of many important signaling pathway for the cells. And this particular mutation is at the second intracellular domain, right at the junction of this intracellular domain with this transmembrane domain. And it was predicted to be deleterious for this protein function. And so we cloned this mutated gene, and with the wild type, we express these genes into the mouse 3T3 fibroblast cells. And then we perform the gene expression profiles to see what kind of gene profile telling us of this mutant vector. And interestingly, this gene signature of this pseudopodia hepatotaxis, actually it's just a fancy name for the cell mobility, okay? So the cell mobility genes is showed up. And also another interesting category is this RHO-A pathway seems is upregulated. So then we look at those cells, growth characteristic of those cells. Those cells that we grow in different concentration of the fetal bilirubin serum, 0%, 1%, 10%. You can see the wild type of mutant does not have difference. Okay, so seems this mutation does not cause any growth difference. However, if we did the cell invasion assay in the Boyden chamber, and we can see that those either we use the FBS as a chemoattractant or use the ligand LPA as a chemoattractant, we can also say this mutant form has elevated mobility shift. And we look at the RHO pathway, and the GTP binding RHO is the active form of the RHO. And you can see under the LPA ligand stimulation that the mutation has elevated the response to the ligand than the wild type. And if we put this system into using another reporter, which is downstream of the RHO-ROG pathway, it's a luciferase reporter. If we expose to the LPA, you can see this mutant has more signaling function than the wild type, which show here in the blue. So from all here saying this data indicates that this mutation really result in enhanced signaling through this RHO-ROG pathway. And this is a scratch assay to show that the mutant form has a much faster cell mobility than the wild type. But if we use this inhibitor, which is a RHO kinase inhibitor, we can stop this, and this is the vehicle control. And in the literature, actually, there's another study published in 2012 showed that the neuroblastoma in that study is detected this RHO-RAG pathway is enriched with the mutation, okay? And this is the diagram from that paper to show that the balance of the GAP, which is a RHO activator, many members mutated in that study. And also the GEF, which is the opposite of the activator, is the inhibitor of the RHO RAG signaling, is mutated. So this all data is consistent with this kind of finding. So we think that probably ROE pathway activation was associated with defect of the neurogenesis genes in the high-risk neuroblastoma, so that those cells cannot go through the terminal differentiation. So here is the summary of this study. The whole genome sequencing showed a massive chromosome alteration together with a small set of somatically acquired expressed mutation in this autopsy sample. And we examined the somatic mutation in addition with the tumor samples, revealed a very rapid accumulation of de novo mutation during the therapy. That has an implication because there might have some resistance towards the therapy coming from this mutation profile. And also this DNA and RNA sequencing will enable us to identify the cell motility driver mutation of this LPR1 gene, suggests that this approach can be used in the precision therapy by identifying the target for each individual patient. And this study also showed that probably Rho pathway activation is important for the high-risk neuroblastoma. So the idea is we can use this kind of approach to identify the target for each individual patient so that we can use precision therapy for the future pediatric trials. So currently, all these patients coming in, we do not know which patients has what kind of mutation. So they are given in the same kind of treatment. The treatment depends on their risk stratification. If it's all high risk, for example, here it says this is all metastatic disease, they all receive the same treatment. But we can use genomic biomarkers to really separate them into different pool of patients. Those pool of patients probably they are response to current therapy well, so they don't need to be giving extra therapy. They can just use the conventional therapy, standard therapy, so they will do well. But for those the patient with poor signature, we probably need to identify what exactly mutation they have so that we can put them into a proper trial to target their each driver mutation. So this driver mutation can be amplification, mutation, translocation, overexpression of genes, and the alternative spliced genes. Okay, so that's the idea. So under this precision method therapy idea, currently we opened a protocol to collecting the tissues for all the patients coming to the NIH, and we can perform different genomic study. This will enable us to understand how useful this method can identify the target in the future. In parallel, there's an effort in the CCR. We are going to use the next generation sequencing to profile the patient, especially those high-risk patients, and so can inform inform clinical management of the patient. So the patient that come to CCR, we can enroll into this program, and then we can do the germline, the somatic sequencing. And at the same time, we can acquire the research data as I showed you in the previous protocol. And all those information we can return to the clinic for guided therapy. And also we can learn from that and to go through this these cycles so that we can understand those disease better. So in conclusion, hopefully I show you that the integrated analysis of the cancer genome identified the biological relevant diagnosis, prognosis, biomarker, and novel targets for the therapy. And those powerful tools can really help to determine the complete genomic portrait of the pediatric cancer at the base level. And this will lead to identification of the key drivers and enable the development of the future novel therapies and the precision therapies. And this is just acknowledge the oncogenomic section. Javed Khan is the chief of the section. And we have very talented and hardworking groups, either in the biological part or the bioinformatics part, because there's so many data for those studies that these two groups really studied very closely to make this study possible. So thank you for your time. Don't know if we have time for some questions. Yes.
Just to clarify, when you say the de novo mutations,
Yeah.
they arise after therapy is instituted?
Yeah, that's so because we have a timeline of those samples, right? So those mutations we do not detect at the very original diagnosis sample. We don't see it in the primary tumor either. They're only at the very end of the disease course. So that's the reason we say it's de novo. Because we sequenced it like 1,000-fold. We don't see any evidence of those mutations. Yeah. Yes.
May I just ask, the fusion transcripts,
Mm-hmm.
they get translated.
Yep.
And do they result in functional protein?
Yep. Many cases they do, especially in the pediatric cancer. So the one I show you, this is all the transcribed as a fusion transcription factors. They really can drive the gene expressions. Yeah, this is well known. Yeah.
Okay, thank you, June.
Okay, thank you very much. I can't.
Okay, so some of the people in the TRACO course signed up to visit the tumor boards. And at the tumor boards, they go through case reports for various patients. Today, we bring the case reports to you. So we have Dr. Olaku talking. He's in the Division of Cancer Treatment and Diagnosis. He's in the Office of Cancer Complementary and Alternative Medicine.
Okay. Please use the mouse since we're doing the online session. Okay, the mic. Okay. All right. So forward, backward. Okay. Good evening, everybody. Thank you, Dr. Modi, for giving me the opportunity to present case reports. Dr. Wayard, I think, has made my work a little bit easier. He presented 2 case reports in his presentation, so makes my life easier. But I hope that at the end of this short lecture, hope to achieve describing history of case reports, recognize the potential roles of case reports, describe case reports, give you some examples of case reports, and outline pertinent information for a good case report. This is one definition of case report, and it's a case report is a formal summary of a unique patient and his or her illness, including the presenting signs and symptoms, diagnostic studies, treatment, cause, and outcome. Case reports started a long time ago, and some of the oldest case reports were probably from texts from Egyptian antiquity papyrus around 1600 BC. It is possible that these texts were copied from previous centuries, and among these were 48 cases discussing injuries or disorders of the head and upper torso. There are certain people or certain names that usually associated with the history of case reports. You have Hippocrates, and Hippocratic doctors or physicians put together case reports. And at the time, they looked at retrospective accounts emphasizing the clinically relevant findings. Some of the hallmarks of Hippocratic case reports that they focus on objective description of findings and observation of the cause. Included in the case report at the time were physical and mental findings. However, the patient's version of the complaints was for the most part absent. Another name is Claudius Galen, who introduced a conversational tone into case reports. And what Galen did was he placed himself as the first person in the case reports. He described his working day, his doubts, his tentative diagnosis, and his interactions with other physicians as the disease unfolds. It appears that in the Middle Ages that Western medicine was dormant. However, at the same time, Islamic medicine seemed to prosper. And the case reports written at the time had both Hippocratic and the Galen as concerns the astute clinical observations. In 17th and 18th centuries, the conversational tone of Galen was still present in case reports. However, there was more emphasis on the patient's subjective experiences. Physicians, the authors tried to put a little bit of drama in their case reports by delaying the moment of diagnosis and the outcome of their story. And this was just to heighten the tension, the narrative tension, and the degree of physician involvement. For example, you can see here, says a girl 3 years old who remained a quarter of an hour underwater without drowning. And this appeared in case report in Philosophical Transactions in 1739. The 19th century dealt less with the patient's subjective accounts of their illnesses, but the focus was more on clinical findings. And at this time, they introduced sections into the case reports, for example, the demographic details of the patient and outline of clinical course of events. So they use more medical terminology at the time. In cancer patients, as I mentioned before, there's been a long history of case reports, and Milos Janicek eloquently describes that case reports are the first line of evidence where everything begins. As mentioned earlier, again, some of the cancer case reports were from the ancient Egyptian papyrus around 1600 BC, and these were the first recorded incurable tumors of the breast. There are several roles that case reports play, and one of the roles is the recognition and description of new disease. For example, in 1999, West Nile encephalitis was first of all recognized in the United States in New York when they had cases of West Nile encephalitis. And as a result of looking at the cases and the reservoir for this virus, which is in crows in the zoo, they were able to come up with methods to reduce the incidence. In fact, they had to spray to reduce the incidence of mosquitoes in New York at the time. Another role that case reports play is in detection of drug side effects, and this could be adverse or beneficial. Quite a significant percentage of drug retractions are usually due to case reports. People report, they report that they found side effects of a particular drug, and that will lead to the body responsible in this country, the FDA, to retract the drug. Another example, which is a beneficial side effect, is sildenafil, which was a drug that was designed by Pfizer in England. And the drug was initially designed to treat hypertension and angina pectoris. They did a phase 1 clinical trial, and they found out that the drug did not have effect on angina. However, they found a side effect that a significant percentage of the men had sustained erection. So that was what led to the development of Viagra. So it came out from an adverse effect of a drug which was meant to treat hypertension. There's been an association between depression and smoking cessation. And as a result of that association, this has led to using antidepressant drugs to treat nicotine withdrawal symptoms because of that association. And all of this came out of case reports. Case reports can also be useful in the study of mechanism of diseases. For example, in this case, you have the maternally inherited diabetes associated with deafness. This is a point mutation borrowing another phrase from Dr. Way's presentation in mitochondrial DNA. This mitochondrial DNA is present in oocytes, but it's absent in spermatozoa. So this disease can only be transferred maternally. Case reports are very important in medical education and audit. And if you're familiar with the New England Journal of Medicine, almost every week they have a case report. One of the ways I became very interested in this area was that when I was in full-time clinical practice, I learned a lot through case reports. And it's also very important for audit when people are trying to look at their practice to see what they are doing right and what they may not be doing so well. It's also important in recognition of rare manifestation of disease. And some of the, as we go through the cases, you will see some examples. Another area that case reports is important is the impact on health policy. If you remember last year when they had the Ebola cases and the first patient who unfortunately passed away in Texas, that led to CDC changing their policy in the way patients are managed or the way hospitals have to deal with cases like that or suspicious cases. So case reports are very useful in describing new disease or diagnosis. Melanoma, case report of melanoma was described by Hippocrates and Rufus of Ephesus. And in 1832, Thomas Hodgkin reported 6 cases, 2 of which are what we know today as Hodgkin's lymphoma. 1957, Dennis Bucket described a tumor in the angle of the jaw of African children, which is what led to what is today described as Bucket's lymphoma. As recently as 1990, Fawcett and his colleagues described 2 patients with a new type of lymphoma called hepatosplenic T-cell lymphoma, leading to more focused research of this new entity. So we go to case reports. So this is a case of vemurafenib-induced progression of breast cancer, a case report. This was a 57-year-old lady who was diagnosed with skin melanoma of the abdominal wall in April 2012, and she underwent appropriate surgical treatment. In October of the same year, she was diagnosed with triple-negative invasive breast cancer, and she had a mastectomy followed by irradiation of the chest wall and ipsilateral axillary subclavicular and supraclavicular regions. She had adjuvant chemotherapy, which included 4 cycles of 5-fluorouracil, doxorubicin, and cyclophosphamide, and 3 cycles of paclitaxel. She had a relapse in the brain in the brain and bones in May 2013. She was treated with biphosphonates, and the brain metastasis was treated using stereotactic radiosurgery. Morphological and immunohistochemical analysis of the biopsied bone lesions indicated that the dissemination was from the melanoma and not the breast. There was a BRAF mutation testing revealed the presence of V600E substitution in the analyzed sample. She had 5 cycles of temozolomide with partial response, and she had a second radiosurgical treatment in November of 2013 for progression of brain lesions. Vemurafenib was administered in December of 2013. She subsequently developed a grade 3 rash, which was detected on the 3rd week of therapy. a grade 1 back pain, and the rash diminished to grade 1 after the discontinuation of vemurafenib. However, some of the popular elements not typical of vemurafenib remained at previously irradiated area of mastectomy scar. Vemurafenib was started at a dose of 720, which was lower than the initial dose. In addition, she received autologous dendritic cell vaccine directed toward multiple cancer testis antigens from February 2014. After 8 weeks of vemurafenib, there was no evidence of progression of melanoma, bone metastasis on CT or MRI scans. However, the lesions at the mastectomy scar progressed. Pathology revealed positive AR, PR, and HER2 and hemoglobin are negative for all melanocytic markers. Molecular testing demonstrated wild-type BRAF, KRAS, and NRAS. And the CT confirmed the enlargement of brain metastasis at 11 weeks of vemurafenib therapy. She had another stereostatic surgery for brain lesions and discontinued the vemurafenib. Letrozole was administered in March 2014, and skin induration and hyperemia were almost completely resolved 4 weeks after discontinuation of vemurafenib. However, a distinct tumor lesion developed near the right mammillary line at the level of the third rib, and analysis was similar to previously excised breast lesions. Unfortunately, the patient passed away May 2014 following progression of the metastatic lesions. These are, it's probably not too clear there, but this shows the outline of the, when she developed the rash. And then this second, the B slide, the dotted lines here was when the initial rash she had, and then when it extended as a result of vemurafenib treatment. And then when it was withdrawn, this is the solid line, showed when it was withdrawn, and the dotted line was how it had improved over a period of time. This is just the histology, the H&E, and the hemoglobin. This is the progesterone, estrogen, and the HER2. This is another case of a lady who was diagnosed with nasopharyngeal carcinoma stage 3. She was treated with radiation therapy for 6 weeks and concurrent bolus cisplatin at those doses and 5-fluorouracil. She was disease-free for 18 months. Subsequently, she developed the back pain, and radiologic assessment identified blastic lesions, which at biopsy confirmed relapsed metastatic nasopharyngeal carcinoma. She had palliative radiation to the painful sacral lesion, and the patient began systemic therapy with weekly paclitaxel, cetuximab, and experienced progression after 6 months. They now started a second line of therapy using gemcitabine at day 1, 8, and 15 in a 4-week cycle. Disease was controlled. Unfortunately, this only lasted for 8 months. She initially received zoledronic acid and with chemotherapy. However, this was later changed to denosumab. This is to treat the osteoporosis and bone pain. Disease progressed with the development of new axillary and iliac adenopathy. She had a third line of treatment with methotrexate. Disease recurred after 3 months. She was treated on a phase 1 clinical trial with a MEK inhibitor. Disease was controlled for 4 months, and she developed a new palpable painless mass in the left breast. Mammography identified a 5 by 4.4 by 1.9 centimeter irregular mass at the 10 o'clock position of the left breast, BRADS category 5. And we can see the mass there. PET-CT imaging also identified the new left breast mass, which radiographically was suggestive of a primary breast tumor. A biopsy was done and revealed malignant cells consistent with primary breast cancer. Immunohistochemistry revealed that there was no estrogen, progesterone, or HER2 expression. So that's the mass there, and that's on PET, that's the mass there. So they looked at all the biopsies to compare them, and they realized that the breast tumor was similar to the original nasopharyngeal tumor, and that both were Epstein-Barr virus positive. So the diagnosis was changed to progressive nasopharyngeal carcinoma metastatic to the breast. At the time of they wrote the case report, the patient was doing well and began the 5th line of chemotherapy. This is just the histology of both the breast and nasopharyngeal tumor. The next case is a 6-month-old girl who was seen by the pediatrician with a 3-week history of bloody streaks on her diaper. As a result of continuous increased vaginal bleeding, she presented to the ER. There was no history of trauma, but the parents found a piece of tissue on her diaper. In addition to that, she also had a heart disorder, and she was being followed up by the cardiologist. All the clinical examination was normal apart from the vaginal bleeding. Blood work was within normal limits apart from the alpha-fetoprotein that was high. The beta ECG was within normal limits. She had an abdominal pelvic ultrasound that showed a solid, well-defined heteroechoic midline mass measuring 3.7 by 3.0 by 3.3 centimeters in the vaginal region. And she had a cystoscopy, vaginoscopy, and biopsy. At vaginoscopy, this revealed a large friable mass which appeared like a cluster of grapes arising from the vagina. And MRI of the abdomen and pelvis showed 2.9 by 3.2 by 3.2 centimeter mass. There was no extravaginal extension. However, there was displacement of the cervix, uterus, and mass effect on the bladder and rectum. There was no evidence of metastasis in the chest, abdomen, or pelvis. Bone scan was negative, and biopsy revealed a tumor characterized by highly atypical cells with reticular architecture and eosinophilic past-positive disease-resistant, diastase-resistant globules with Schiller-Duval bodies. Immunohistochemistry was positive for focally positive for alpha-fetoprotein and negative for epithelial membrane antigen and CD30. And the findings were consistent with yolk sac tumor. You can see the tumor here, here on MRI, there, and there. So this is just the histology showing the Schiller-Duval bodies and the focal expression of alpha-fetoprotein. So she had primary surgical resection that showed a pedunculated posterolateral vaginal wall 3 to 4 centimeters from the upper third to the mid-vagina with a width of 1 to 2 centimeters. At surgery, the tumor was resected completely, and there was no tumor identified post-operatively with cystoscopy. Biopsy was consistent with a yolk sac tumor. However, the margins were involved, but they were negative for vascular and perineal invasion. The patient was stratified as intermediate risk and received 3 cycles of cisplatin, bleomycin, and etoposide as per the Children's Oncology Group protocol, AGCT 0132. AFP decreased to 454 nanogram per ml 2 weeks after surgical resection and before starting chemotherapy. It decreased further to 21 nanograms after 4 cycles of chemotherapy. However, after 3 cycles, it remained at 22. MRI performed at the same time showed no evidence of residual tumor. Given the abnormal AFP, the team decided that they would give consolidation, 3 consolidation cycles of the same chemotherapeutic agents. And after 2 months, after completion, the AFP came down to 13 nanograms per mil, beta ECG remained normal, and repeat MRI after 6 cycles and 2 years after completion of therapy showed no residual tumor. Patient continues to do well clinically with no evidence of recurrence more than 2 years after the completion of therapy. Another case, 37-year-old lady in her 6th pregnancy, had 3 normal deliveries, had 2 miscarriages, went to the antenatal clinic for routine ultrasound scan at 16 weeks. The ultrasonographer picked up a 16-week single fetus with bilateral asymptomatic multilocular solid cystic adnexal masses measuring 8.9 on the right and 7.6 centimeters in the left ovary. On Doppler, the cysts were not vascular, there was no ascites, and peritoneum and liver appeared normal. She did not have any medical problems or any past family history of endometrial, ovarian, colorectal, or breast cancer. The lactate dehydrogenase levels were elevated and there was no hypercalcemia. Ultrasound scan, you can see the cysts in the ovaries. CA125 was high, 10-15 U per mil, and CA15-3 was also high. CA125 was repeatedly high with a range of 10-15 to 10-25, and they had to have a multidisciplinary team to manage the patient. She had exploratory laparotomy at 18 weeks, and that confirmed the presence of ovarian masses, 9/10 on the right and 7/6 on the left. The capsules were intact. She also had 2 omental nodes measuring about 6 centimeters. Both ovaries were removed. Part of the omentum was removed. The appendix was also removed. And they had peritoneal washing, and multiple biopsies of the periatrocolic, prevesical, and diaphragm were performed. Palpation of the pelvic and para-aortic lymph nodes were negative, and the post-operative course was unremarkable. However, histology confirmed a trabecular and sheet of small malignant cells with dark ovoid nuclei with many mitosis consistent with bilateral small cell ovarian cancer, stage 3 in both ovaries, and the omental nodules. So that's the gross picture. That's the uterus, that the ovaries with the ovarian tumor. Again, this is the omentum. The tumor is held within the fingers of the surgeon there. Following surgery, she received 6 cycles of adjuvant chemotherapy with cyclophosphamide and carboplatin. CA125 levels dropped to normal following second course of treatment. Pregnancy remained uneventful. At 38 weeks pregnancy, she had exploratory laparotomy. They did a cesarean section followed by a hysterectomy, and they took multiple biopsies. There was no evidence of residual disease after surgery, and histopathological diagnosis did not reveal any secondary tumor tissue in the uterus, with a section of the omentum showing area of fibrosis and foreign body giant cell reaction with no secondary deposits. She had a female infant with 900 grams, placenta was normal. 23 months after diagnosis, the patient was doing well with no evidence of disease. Now we go to rare cases. In rare cases, it's very difficult to put a case series together because there are very few cases available. So what the clinicians have to do is to rely on the evidence of the few cases to try and make sense whenever they come across a patient with similar disease. This is a 64-year-old male who presented to his primary care physician with a history of non-specific fatigue. Physical examination was unremarkable. Laboratory studies revealed profound anemia, had blood transfusion 6 units, and they suspected that the patient must be bleeding from somewhere in the abdomen. They did a colonoscopy that was unremarkable. They also did an esophagogastroduodenoscopy. which showed a large 6.7 by 5.3 centimeter ulcerated mass along the greater curvature of the stomach. And the biopsy, endoscopic biopsy, demonstrated nests of cells with large nuclei, prominent nucleoli, and abundant cytoplasm expanding into the lamina propria. Histological examination revealed immunohistocompatibility positivity for SOX10, S100, MAT1, HMG45, confirming malignant melanoma. They did a thorough examination of the patient. They did not find any concerning cutaneous lesions. They did a PET scan, which was able to identify the tumor. Surgical exploration demonstrated a large pigmented ulcerated mass along the greater curvature of the stomach. Mass was excised with a subtotal gastrectomy and lymph node dissection. So again, that's on PET scan, different views. That's the mass there, and on CT scan, it's the tumor there. Pathological specimen revealed a large melanoma of the greater curvature of the stomach, about 10 centimeter in the greatest diameter. The tumor had already invaded the muscularis propria and into the subserosal, but did not invade the visceral peritoneum. Lymphovascular penetration was evident. That's the tumor from the specimen. Again, they confirmed the histological specimen with the positivity of the MAT1 and S100. Immediate postoperative period was unremarkable. They decided that they were not going to give any adjuvant therapy. About 18 months later, patient presented with small bowel metastases that were not amenable to resection. Unfortunately, he passed away with due to diffuse gastrointestinal necrosis secondary to thromboembolization caused by cardiac arrhythmia. This is just some of the histology. This is the H&E, and this is some of the histocompatibility positivity. This is a case of a 64-year-old male was admitted to the hospital with a history of progressive dyspnea and cough. He had undergone a right lobectomy in October 2006 for hepatocellular carcinoma. After 14 months, the patient scan revealed multiple metastases and left adrenal gland metastasis. Some of the tests done, serum protein induced by vitamin K absence or antagonist 2 level was abnormally elevated. The patient was treated with 5-fluorouracil, adriamycin, and carboplatin. Disease progressed after 2 cycles. Patient received 2 more cycles of second-line chemotherapy, which comprised of 5-FU, etoposide, and carboplatin, and 3 cycles of third-line chemotherapy with oral capecitabine. There was no response, and the patient was transferred to another facility in February 2009. And this is just his blood work. The alpha-fetoprotein was 16.5, I was just slightly high. Chest radiograph revealed miliary nodules in the lungs, and CT scan of the chest and abdominal pelvis indicated miliary metastasis and metastatic abdominal lymph nodes. So you can see the chest X-ray with all the nodules in the lungs, CT scan around the liver, the lymph nodes. So at the other facility where he was undergoing palliative care, he was to be seen every 3 months. He continued to have his cough and dyspnea, and there was no change to the chest radiograph. However, the second visit in September 2009, the patient had improved, and the cough and dyspnea had stopped. The chest radiograph revealed that all metastatic nodules had disappeared. And this is the chest X-ray. Serum AFP had dropped down to 1.5, and whole body PET scan December 2009 revealed that all metastatic nodules in the lung, as well as lesions of the 2 adrenal glands and lymph nodes, had disappeared. The only thing the patient said he did differently was he had taken a herbal medicine, Dendropanax mubifera levil, for approximately 1 week on the recommendation of his family. And all the biomarkers were down. As at May 2013, the patient was still alive. And you can see February 09, June 09, September 09, the miliary nodules in the chest, and it then cleared there, and up to May 2013, his chest was clear, and all the blood work was within normal limits. So was it spontaneous regression or what he took? I don't know. This is the case of a 12-year-old girl that was referred to the pediatric surgery department. 2-month history of pain when she passes, when she defecates. She had diarrhea and weight loss. She had a family history of second-degree relatives of colorectal cancer, iron deficiency anemia, low albumin, and high erythrocyte sedimentation rate. She had a colonoscopy that revealed a bleeding ulcerated polypoid mass located about 5 centimeters above the anal margin, occupying greater than 50% of the lumen. The biopsy confirmed squamous cell carcinoma with positive immunohistochemical staining for P63, vimentin, cytokeratin AE1, AE3, and Ki67 was 70%. This is just the tumor here. This is AEI, AE1 and AE3, and this is the Ki67, the C. These are some of the other markers. She was treated with mitomycin, 5-fluorouracil, and radiotherapy. And CT scan performed 3 months after showed a reduction in the tumor volume with thickening of the parietal rectum wall and decrease in size of the lymph nodes. Colonoscopy confirmed that there was an absence of the intraluminal mass, and biopsy revealed chronic inflammatory infiltration negative for malignancy. Staining for P63 was negative, and 6 months after, PET-CT revealed progression of the lymph nodes metastasis without any local progression. She had a colonoscopy that did not show any change in the rectal mucosa, and biopsy results remained negative. And following lymphadenectomy, pathology report and immunohistochemical study showed metastasis of the adenocarcinoma without the squamous cells, reacting to cytokeratin 20, CDX2, and negative for P63. So she was diagnosed as adenosquamous carcinoma of the rectum, stage T3N2M0. The disease rapidly progressed with liver metastasis and enlargement of gastrohepatic lymph nodes. She was treated for with chemotherapy for metastatic colorectal disease. She was negative for 12, 13, and 61 codons of the KRAS gene. She had FOLFOX6 plus bevacizumab, and 3 months of treatment. Patient was stable, has stable metastatic disease without any toxicity reported. So that's the tumor there, and the rectum, when she initial treatment, there was some improvement, and some of the metastasis in the liver and lymph nodes. So our case reports are important in today's era of evidence-based medicine. Some people believe that case reports are not important because a single case report cannot provide evidence of efficacy or safety in diagnosis and treatment of a disorder. Albrecht and his colleagues looked at 100 case reports in the archives of dermatology, and they had certain concerns like that there was publication bias in support of positive results, that some of the, there was exaggeration of claims of efficacy and safety, there was inadequate informed consent reporting and underreporting of patient-centered outcomes. From a business perspective, case reports are rarely cited. They create a dilemma for journal editors because they negatively affect the impact factor. And quite a number of researchers will prefer to publish their work in in journals that have a high impact factor. And this may also have an impact on companies on which of the journals they will use their dollars to advertise their products. So evidence-based medicine is exclusively concerned with finding the best evidence for clinical decisions. For example, what particular therapy or diagnosis test do we apply to a particular patient? Whereas randomized trial, what it does is to give an evaluation of therapies or tests, especially when the clinical value is not immediately clear-cut. However, case reports have their aims and are equally important in the progress of medical science and education. Some people do meta-analysis or systematic reviews of case reports. An example is Nayfield and Gorin. They looked at 21 cases of tamoxifen-related ocular toxicity in breast cancer patients. As a result of their review, they were able to get a clearer picture of the nature and distribution of the toxicity, as well as the severity of the ocular findings. They also recognized the difficulty in attributing ocular findings to tamoxifen and other competing causes of retinal, macular, and corneal abnormalities. Nordin conducted a 20-year literature review of both case reports and series of primary carcinoma of the fallopian tube, and that led to describing, having a more appropriate outline of patient characteristics. They were able to hypothesize on the underdiagnosing of cases, causes of treatment failure, and lack of clinical trials, controlled trials. But also they found the usefulness of a second look laparotomy for monitoring disease response to the treatment given. We looked at case reports of herbal therapy used by cancer patients. 18 case reports had apparent anti-tumor effect and 21 had toxic effects. There were clinical trials already done in compounds like green tea, phytoestrogens, mistletoe, Ganoderma lucidum, noni, silymarin. And also there were some prospective studies done for PC spares, saw palmetto. However, many of these herbs that showed promising case report findings have either not yet been explored or the results have not been reported in English, because we confined our review to English case reports. Bless you. When you do a meta-analysis of case reports or case series, only patient characteristics and case outcomes can be better assessed at this level of clinical research. However, in situations where there is no adequate evidence, the best of the first-line evidence must be taken into account. What is the impact of case report on medical research? The one thing I want you to take away from this table is that case reports that were followed by clinical trials, only 17% of case reports are followed by clinical trials. This next slide, we looked at case series, and the same question, case reports that followed published trials, 31%. So there's a slight increase in percentage between case reports and series, and that's not surprising. How do you write a good case report? Some smart people came together in 2013, called the CARE group, and they gave the CARE guideline, which is just case reports, and they suggested that a good case report should have a title, have keywords, abstract, introduction, patient information, clinical findings, the timeline of the treatment, diagnostic assessment, therapeutic intervention, what were the follow-up and outcomes, have a good discussion. They should also include the patient perspective and the informed consent. So what is the takeaway from this case report lecture? That if case reports are going to be useful, they should be written in an organized and structured manner, which the CARE group had recommended. That case reports are very relevant in medicine today. We saw in the outbreak of Ebola last year that finally found its way to the United States, that case report is what has led to the clinical trials that they are doing now. In rare instances where clinical trials are not possible for ethical reasons, case reports of series may be the only evidence available to recommend treatment. Thank you for coming and listening. I just want to commend my colleagues, Dr. White and Dr. Farazia. Thank you very much. Any questions? Yes, ma'am.
I have two questions.
Yes.
First question is, what do you mean by patient's perspective when you write a case report?
Well, from their view, they believe that when we write case reports, it's the authors, the physicians write the case report, what they think. What they wanted to see, they want the patient's perspective so that I guess that would go along the area of patient-reported outcomes, so that this is what the patient felt about the treatment that they've gone through. So they wanted to include that in case reports. Like I said, it's just a recommendation guideline. Nobody, I'm yet to see a case report yet that has. So, yes.
My second question is, I know that in terms of level of evidence,
Mhm.
case report is like at the bottom.
Yes.
In terms of considering what level of evidence that is. So if you do a meta-analysis,
Right.
would that elevate it or would it stay at the same level?
It's generally the same level, but what it does is to help to generate new hypotheses. So that when you do a meta-analysis, you can find some information that will now make you go for something else. So it's to generate information that will generate hypotheses. Yeah. Any other question? Thank you very much. Thank you, Dr.